All right, welcome back to Ultrasound Grand Rounds this week. Pretty excited to be here this week, as always, with you guys with some ultrasound education, a little bit of what we do here at MetroHealth. Over the last few weeks, we've been talking about soft tissue ultrasound. We talked about cellulitis versus abscess. We talked about other lumps and bumps we can find. We talked about necrotizing fasciitis. If you missed any of those lectures, they are all posted up on the YouTube channel. Head on over there, watch those, get caught back up to where we're at. While you're there, hit that subscribe button. Hit the notification bell if you like the videos, share them with your friends. We'd really appreciate that. But today we're going to talk about another soft tissue topic. And without further delay, let's switch on over to the presentation and we'll see what this case is today for us.
Today, what we're going to do is we're going to basically start us off using kind of a case as our way of getting things started. So it'll be the case of a swollen thigh. So what I want you to do is imagine that you are in the ED seeing a 41-year-old patient who was running, unfortunately tripped and fell and landed on his left thigh, right? Now, this case is 100% made up. But it's based on, things that you would reasonably see in the emergency department. And obviously the clinical scenario is something that could be applicable in this situation. So imagine yourself seeing this runner fell, landed on the side. They're saying, hey, doc, I've got some pain and I got swelling in the lateral part of my left thigh, right? The vitals look pretty good. Patient's otherwise well appearing. But when you look at the patient, you notice that there is some swelling there, right? You can see that little lump on the lateral side of the thigh and you can see some ecchymosis. So they definitely took a pretty good tumble. And so as the inquisitive POCUS users that you are, you decide to grab your ultrasound and start looking with the ultrasound, see kind of what you could find and what's causing this lump that you're looking at. So here's image number one, lateral side of the thigh using the curvilinear probe. And you can see kind of the big thing to note is there is a very large, let's go back there, large, mostly anechoic fluid collection in the soft tissue. It's got some internal echoes to it. It's very linear, fusiform type appearance, kind of got a kind of lumpiness to the nature of the wall. So that's image number one. Now, to get a little bit of a context of where we're at, we kind of have to look at what's the surrounding structures. And so if you look at this one, this is image number two, you can see obviously the skin is going to be the very top layer, right? That very hyperechoic thin layer at the top. You can see that marbled subcutaneous layer that we've been talking about over the last couple of weeks. And that bright white line that's indicated by that positive arrow sign, right? That is the fascia. And so what we can see is that our lesion is kind of somewhere between that subcutaneous layer, but superficial to the fascia. You can see the tip of that lesion kind of as you're as you look to the right-hand side of that screen. And so this is going to be a fluid collection in the subcutaneous layer that's superficial to the fascia that's causing this patient's swelling and their pain. So the question then becomes, as always, what is causing this, this fluid, right? What's the differential diagnosis? And so if you think about it, the differential diagnosis could be a number of things, right? It could be, well, they fell, right? So a hematoma is certainly reasonable and likely in this situation. You could argue for a seroma, right? Although if they acutely fell today, the seroma seems to be less of a likely thing today versus, if they came in a couple weeks later, right? So hematoma versus seroma, abscess, certainly a possibility, right? But again, the story isn't consistent with this indolent, like infectious process that kind of progressed and developed and got worse. The guy was running and he fell and he landed on his leg, right? And so kind of that hematoma seems to be the most likely, except for this mystery diagnosis, which I guess if you are attuned to the lead up, the mystery diagnosis is probably the one that we're going to be talking about for the rest of the day, right? So that's the differential diagnosis for this particular patient. Let's say a CT scan was performed, and you could see something like this, right? So you have that, you can see obviously the bone in the middle, right? You can see the muscles kind of surrounding that bone, some subcutaneous fluid, superficial to the muscles, but then there's that large fluid collection. Obviously, this is a different patient because it's not in the same place as the last one. You can see that large fluid collection kind of in that subcutaneous layer. And so all of these clinical findings, all the ultrasound findings, all the CT findings that we're looking at here is consistent with the entity called a Morel-Lavallée lesion, right? And so this is something that's interesting, something we see from time to time. I've certainly seen a couple of these over the course of my career so far. And it has some interesting implications for management and for long-term follow-up that we should probably be aware of. So I think it would be, good for us to talk about it. So the first thing, just to kind of go back a little bit from a historical perspective, this lesion was first described by a French surgeon named Maurice Morel-Lavallée, right? It's horrible pronunciation of French, but anyway, it is what it is. We're kind of following that French theme. We talked about Dr. Fournier last week. We're talking about Dr. Lavallée this week. This was originally described in like the 1950s, or not 1950s, the 1850s, right? And there's some discrepancy in whichever source you read. Some say 1860s, some say 1850s, but kind of the mid to late 1800s, Dr. Lavallée described this entity. And essentially what a Morel-Lavallée lesion is it's a closed degloving of the subcutaneous skin and subcutaneous layer off of that deep fascia that results from some trauma to that area, right? And what you get in its as a result of this is a dead space or a potential space for fluid to accumulate. And so if you look at this image here, this kind of shows you a little bit what's going on. You have that skin and subcutaneous layer, right? You have some form of either a direct impact to that area or some shearing injury that separates that fascia from the subcutaneous layer. And when you do that, right, you result in a couple things, right? You result in disruption of the vasculature, so like the arterioles and the capillaries and all that stuff, and you disrupt the lymph drainage, right? And so when you disrupt that, you obviously have leakage of those fluids into that area and leads to accumulation of fluid in the subcutaneous space. So you have, blood in the space, you have, serous fluid in the space, you got lymph fluid in the space, you also have all your fatty tissue that's in that area that's kind of in that space as well, right? And so you get this accumulation of fluid and debris kind of in the subcutaneous layer as a result of this closed degloving shearing type injury, right? So this happens in a number of places. As a general theme, it tends to happen over osseous protuberances, right? So the hip, right, the lateral thigh, the gluteal region, they tend to be very, very common places for these things to happen. Like the greater trochanter of the hip, a third of the cases happened there, right? And the cases that I've seen, obviously the one, the distal femur was one of them, but I've also seen some on the lateral thigh, right? But they happen kind of around these bony protuberances, kind of around the trunk, around the extremities, on the back, things like that, right? So those are common locations that they happen. And if you think about it from just kind of a cascade of events standpoint, what happens is you have that injury, right? You have that fluid collection, that blood, the serous fluid, the lymph that accumulates in that potential void, right? As that sits there, right? All of that triggers an inflammatory response, right? The body's like, hey, this is weird. This is not normal. This needs to be dealt with. And so it's dealt with through the inflammatory cascade, right? Unfortunately, rather than just kind of making the whole process go away, the inflammatory cascade is like, this thing is foreign to me. I don't like it. I can't get rid of it. And so I'm just going to wall it off, right? We've seen this phenomenon happen elsewhere. So it forms this fibrous encapsulation of this area, right? And that then, when it's kind of encapsulated by this fibrous material, then hinders our ability to reabsorb this thing, and it tends to just sit there and potentially even accumulate even more, right? And so you may ask, okay, fine, you have this injury. I'm starting to get the feel for this is not good. I mean, the fact that you're devoting an hour of our time listening to this means it's not good. The fact that you have this inflammatory cascade and this encapsulation means it's not good. But what really is the big deal here? Well, the big deal is, as you have this, you can have progressive expansion that can put pressure on the surrounding tissues, and you start getting like fat necrosis, and eventually you get skin necrosis. And so you can have these chronic wounds that can develop. It can lead to chronic pain. It can lead to cosmetic deformities of that area, and ultimately be a source of potential tissue or soft tissue infections in the future. And so there's a long cascade of events that can lead to that can result from these Morel-Lavallée lesions that lead to untoward things that we don't really want for the patient, right? And so, with that context in mind, I mean, this is obviously something really important and something we should then be looking out for. And so the next question is,
Well, how do I know these things are there, right? How do they present? When should I be worried? I'm obviously not going to worry about every single trauma patient with a Morel-Lavallée lesion. So when should I worry? And then how should I go about starting to consider my treatment modality or paradigm or algorithm for these, right? And so from a clinical presentation standpoint, it generally tends to present as soft tissue swelling in the context of trauma, right? And so one thing that I'll oftentimes do is when I have patients who particularly fall, right, and they land on their side, I want to see that side, right? I want to look at it and say, is it just tender when I push? Do you just have some bruising, or is there something else going on, right? And that something else is what I'm really interested in. So is there swelling in that area? Is there fluctuance in that area, right? A lot of people, when you feel it, it feels like there's a water balloon underneath the skin. And I've seen it described in some of these case reports is, that water balloon feeling, right? And so it's very odd, right? You can push on the thing, and it's just like very jiggly, kind of fluid filled thing, right? And so soft tissue swelling, fluctuance, because there's that fluid under there that's kind of releasing that subcutaneous layer from its bond to the fascia, that skin is going to be very mobile, right? So it's kind of, you can move that around a little bit. And you'll likely have some degree, at least in the acute phase, of ecchymosis in the area because it was injured enough, right, to create this bruising deep down in the subcutaneous fascia space, but also kind of further up in, the soft tissue and the skin space, right? And so you should see some sequelae of that as well, right? And so that's generally how it presents. Again, it's generally associated with trauma, right? And so you don't generally have these spontaneous Morel-Lavallée lesions. I don't think I've seen one in the past, but you'll usually have someone like I fell down the stairs, or I fell, or I got hit by a car, or various other things like that. That is the precipitating event for these particular lesions. And unfortunately, it can be kind of a sinister presentation, right? Up to a third of them can go unnoticed initially, right? And it's only as they don't heal, right, they progress, that you start noticing these effects. And so I think while you can kind of rest a little bit on the fact that sometimes they're a little bit difficult to diagnose, I think this also means that we need to have at least in the back of our mind that this is a possibility and tune our radar to the potential that this could be going on, especially in these patients who have injuries to those high risk areas like, peripelvic, perifemoral, injuries. They can be associated with that. And also they can be associated with, patients who have fractures of their pelvis or their acetabulum or their femur. So again, these fractures denote a high mechanism injury that would then also put these, soft tissues at risk or be a potential, mechanism, for these soft tissue injuries. And so fortunately, a lot of these we're going to be imaging in other forms, so you may be picking up on this incidentally. But when you have someone who you have concerns for these entities, you should also kind of pair that up with, do they have the potential for a Morel-Lavallée lesion? And strip them down and take a look at their skin and feel their skin and see, is this potentially what's going on, right? So from that standpoint, kind of moving on to treatment, how do you treat these things? There's a range of treatments, right? Ranging from conservative therapy to see what happens, kind of with ice and compression. Certainly some of the case reports that I was reading talk about the fact that, you initially do this, they call it the cryotherapy. So you put ice on it, you wrap it up, get it real tight, try to get the body to reabsorb that fluid as much as possible to prevent that long-term chronic inflammation, that long-term encapsulation. So if you can get the body to get rid of it first, great, that works great. Sometimes that's not possible, and is going to then need some form of drainage, right? Whether it be percutaneous aspiration, or if you need to go into the operating room to drain it and place an actual like JP drain or something to that effect. Or if it's been there for a while and you have that encapsulation, well, now you need to get in there, you need to drain the thing, you need to get that capsule out, kind of debride the tissue away to normal subcutaneous tissue so that you can allow that fascia and that subcutaneous tissue to readhere and to heal back up. And so obviously I'm not a surgeon, I don't know all the surgical techniques, but that is something that would be involved from the surgical side that would be a potential treatment for these patients. And so one of the sources that I read, and again, I don't know how much weight this particular number holds, but one of the sources said that if the thing's greater than 50 cc's of fluid, it's going to probably need some form of drainage. So I think ballparking it, like if you have a large collection, it's going to probably need some more active drainage at some point than if you have a small collection, which may just be taken care of with some ice and compression. But I think if you're talking about this entity, you probably should be getting your surgeons on board and letting them help kind of make that differentiation between, am I going to do an operative or procedural drainage strategy, or am I going to do more of a conservative ice compression drainage strategy? But that's kind of the general paradigm for how these things are viewed, right? So the next question then becomes, well, okay, clinically, I know how to suggest this, right, or be aware of this. We talked a little bit about kind of what we need to do if we find it. So how do I get to making that diagnosis, and specifically what imaging modalities do I need to be thinking about as I'm imaging these patients, right? And so given the fact that this is Ultrasound Grand Rounds, ultrasound is going to be a huge component of that, and that's kind of where we're going to end up. But before we get to ultrasound imaging, we want to talk about really the typical or the conventional imaging for Morel-Lavallée lesions, at least in 2024, right? And so that falls under two major headings: CT imaging and magnetic resonance imaging, or MRI imaging. Probably not going to be picking these things up too well on plain film, X-rays. So it's going to be one of these cross-sectional forms of imaging, right? And when I say CT, it's certainly a possibility, and it's probably going to be one of the frontline tests that we do, at least from the emergency department, to make the diagnosis if we're not ultrasounding them, just because CT is ubiquitously available, it's rapid to get in and out of, and it also can tell me not only the extent of the injury, but also what other injuries are there in the process. And so the typical scenario is probably going to be something to the effect of, I have this patient who has this, thoracoabdominal injury, pelvic injury, and I CT'd them to look for injuries, and I found it on CT. So it may be an incidental finding. Or if you have this large thing and ultrasound's not available to you, or you could get your consultant on board and they ask for it, you may be CTing through this lesion to get more of a global, holistic perspective of what's going on with this lesion, right? Ultrasound's great, right? And we're going to advocate for it strongly as an initial, maybe potential screening modality. But what it's limited to is its field of view, right? And so if you don't have a broad field of view, you're going to only be able to see what's narrowly under that probe. And so CT is going to be able to rectify that problem and basically show you the whole thing at once. And so CT is probably going to be your front end test. If you read the literature though, the most ideal test for a Morel-Lavallée lesion to make the diagnosis is going to be MRI, right? Because it not only tells you all the benefits that the CT has, where it's like, how big is this thing? How broad is this thing? How, where is it at? But it's going to be able to give you some characteristics of that soft tissue and that fluid and help you differentiate that from other forms of fluid collections. Again, most is probably going to be differentiated by your history, but the MRI is going to be able to help you do that, help you further differentiate that. And this is probably the bigger modality for the MRI is, okay, we tried conservative therapy, and this will be for like your orthopedists. Things aren't getting better. Now let's MRI this thing and see where we're at in terms of, do we have an encapsulation? Like, do we need to get in there? How big is this thing? How far is this thing? So it may be more of an operative, like a follow-up and operative planning type imaging modality, as opposed to straight out of the ED. This is what's going on with the patient. It's probably not going to throw a lot of people in the MRI machine just to make the diagnosis when I didn't know it was there to begin with, right? So that's your typical imaging modalities. I think for the remainder of our time, and this will be a little bit shorter today, but for the remainder of our time, we can focus in on ultrasound, because ultrasound is a great, non-invasive, repeatable, safe imaging modality that we can bring to the bedside and use to evaluate patients with Morel-Lavallée lesions, to help us kind of say, okay, I'm on the radar. Now I can start, getting consultants on board. I can start ordering more expensive tests. This is something I need to be worried about, right? So when you look at it, there's several characteristics of Morel-Lavallée lesions on ultrasound, or several ultrasound characteristics, right? And so this is an example of a lesion that we scanned that shows kind of the typical features, right? And so the typical features fall under 5 major headings, right? Those are location, shape, echogenicity, homogeneity, and the margins, right? And so as you think about scanning for Morel-Lavallée lesions, you're going to be answering some of these questions, right? Where is the thing at, right? And so there was a nice retrospective review that was published in the Journal of Ultrasound in Medicine that basically polled, a couple hundred patients with, applicable soft tissue ultrasounds, and they looked at the Morel-Lavallée lesions and characterized the lesions based on the findings that they had. And all of the patients that had Morel-Lavallée lesions had the location of the lesion in that subcutaneous fascia interface, right? It's deep to the subcutaneous tissue, superficial to the fascia. So again, it goes along with the nature of this study. It's a degloving of those two different layers, and then obviously you have the interposition of fluid in that space, right? So they're all in that subcutaneous space, right? So what about shape, right? They found that there could be multiple shapes to these things, but most of them had this fusiform kind of elongated shape. That being said, some could be more flat and some could have more of a lobular appearance, but they all kind of had this kind of most of them had this fusiform type appearance. And the ones that I've seen have been kind of this, right? For echogenicity, there's a range of echogenicity from completely anechoic, right? So no echoes, just black fluid, to there's echoes in it, right? But generally it tends to be hypoechoic to the surrounding tissues, right? And this kind of gets back to what is that material composed of, right? And how does this lesion evolve over time? And so there's going to be some potential changes as this thing evolves, right? But most of the time, it's going to be this decently anechoic fluid, with maybe some echogenicity into it. The homogeneity, this is going to be the one that actually, unlike the echogenicity, changing over time, the homogeneity is the one that definitely changes over time. And if you think about it, you generally start off with like this hematoma, maybe some fat in there, and eventually the hematoma will settle out, right? And you're left with kind of the serosanguinous fluid. And so you can imagine that it becomes like this heterogeneous stuff that's going to transition to more of a homogeneous appearance. But it can be anywhere on that spectrum, right? You can have heterogeneous appearance of the fluid in that subcutaneous area, or you have homogeneous appearance of that fluid in the subcutaneous layer, right? And finally, on the margin standpoint, again, there's a little bit of an age component to it. So if you imagine like you just degloved your subcutaneous layer off of your fascia, right? There's going to be some irregularity, at least to the superficial margin, where you have, those lobules of fatty tissue in the subcutaneous layer that, are kind of hanging there, right? If you encapsulate that, kind of over time, that becomes more encapsulated, then those margins tend to smooth out a little bit and you kind of have that smooth type of appearance, right? And so if you want to put this in kind of a little bit more of a grid fashion, acute versus chronic, you can see location the same across the time spectrum, right? From a shape standpoint, maybe more in the acute phase, you kind of have that lobular type of appearance, and as the thing kind of matures and settles out, it becomes a little bit more flat. But realistically, and according to the paper, you can have any of those different shapes across that time frame, right? From an echogenicity standpoint, they didn't see any difference across the time frames, but from a homogeneity standpoint, that's where they saw the difference. Kind of as that lesion matures, becomes more encapsulated, becomes more serosanguinous, you might see a change from kind of more of a heterogeneous mixed appearance to just a kind of a smooth homogeneous appearance, right? And then finally, from a margin standpoint, it makes sense as the thing matures and becomes encapsulated, you tend to take your borders from kind of potentially more jagged, irregular to more of a smooth type border, of a well-contained fluid collection as that becomes encapsulated. So can you precisely date and age these things? Probably not. But these are general tendencies that you can see as you're scanning these patients. And I think a lot of the age is going to come down to history. Like the patient said they fell, 2 months ago and they still have this thing, versus the patient said, yeah, I literally was just out running right now and I just fell. Right. And so a little bit of a clinical judgment is going to have to come into play there as well. So again, this is that example, kind of that nice panoramic view of that lesion that exists between the muscle. Kind of you see that striated muscle with the fascia on top, and then that subcutaneous layer that's lifted off of that fascia, above that lesion. And if we go back to the images that we started with, we can kind of go back and look and say, okay, I see some of the stuff now, right? It's that fusiform, that lenticular, or that long fusiform, kind of mixed echogenicity, fluid collection, kind of deep to that subcutaneous layer, that's above that muscle, right there. And if we kind of go back to that other image where you can see the fascia, you can really point out, your anatomical features of where these things are at. So hopefully that was helpful. I know this is a little bit bit shorter, which is probably a good thing. But just to recap a little bit, Morel-Lavallée lesions are lesions that happen as a result of trauma, right? So you should be suspicious of it in cases with trauma that have direct impact or a shearing impact, particularly to these bony protuberances, most notably kind of around the torso, kind of the pelvic area, kind of the greater trochanters, the pelvic area, right? They are essentially a fluid collection in between the subcutaneous layer and the fascia that can become chronic, right? And can cause a bunch of downstream complications in terms of that wound and that healing. And so they definitely need some surgical involvement, either at the front end for management recommendations or eventual percutaneous or operative drainage, right? And finally, ultrasound can be a good initial diagnostic tool when you have this concern. When you're like, I don't know if I want to pull the trigger on a CT scan just yet, you can go to the bedside with the ultrasound, look and say, do I have that characteristic fluid collection in that area? And that would suggest this lesion. Or when you happen to be scanning and see this lesion, like, hey, I got fluid between the subcutaneous and the fascia, and I have this trauma history, well, this is what I'm dealing with, and this is the next steps I need to do. I need to get surgery on board, probably will eventually get some cross-sectional imaging, and then what should I expect in terms of management? Well, depends, but it could range from that ice and compression all the way up to, hey, we'll take this patient and get this thing drained out. So with that said, any questions about this particular entity before we kind of wrap things up here today?